Good evening to everyone present here as with today. This is Shriyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Shumitro Ray. Sir is an MBBS MD, Fellow of Royal Society of Medicine, Cardiology Society of India, Indian College of Physicians, European Society of Cardiology, American College of Cardiology, Society for Cardiovascular Angiography and Intervention, consultant at Amri Hospital, Kolkata. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is cardiovascular risk reduction. Now, without any further delay, I would like to welcome Sir to our forum and would like to hand over the session to him for his precious talk to begin with. Over to you, sir.
Thank you and good evening. Welcome all. Today's subject is prevention of cardiovascular disease. And as you may appreciate, prevention is the mother of cure. The saying is still very relevant, if not more relevant than ever. First, go through certain facts. That cardiovascular disease is the commonest cause of death in India over the last 20 years. Almost 30% of total death was accounted for by cardiovascular disease in 2016. And also we must appreciate that the prevention works. 40% of the reduction seen in coronary heart disease mortality related to treatment improvement. And while more than 50% improvement was ascribed to change in risk factor. So when we are saying 30% total death, and this is reduced by various intervention, half of the risk is reduced by change of risk factor, and half of the risk is reduced by treatment of the actual disease. So you can imagine that prevention or control of risk factor is even more important than actual treatment when the disease occurs. This is a very good study in our hand by Salim Yusuf and group published in Lancet in 2004. Pretty old, almost 20 years old study, but it's still an eye-opener called Inter-Heart study. And it has very emphatically established that cases and controls from 52 countries representing every type of race that is living in the world. And they found out that population attributable risk more than 90% for 9 easily measured risk factors. That means if we can control the 9 risk factors, then we can reduce the coronary disease by 90%. Only 10% remains. And what are those risk factors? The topmost of the chart is blood cholesterol. That is ApoB by ApoA1 ratio. So if you see here, neither LDL, not triglyceride, not HDL is mentioned, but ApoB represents LDL and A1 represents HDL. So it is a ratio of LDL by HDL, which is contributing population attributable risk almost 50%. Second comes category is current smoking. We'll show you that if you stop smoking, the risk reduces dramatically. And this population attributable risk for current smoking is almost 35%, closely followed by psychosocial factors. Now, I am sure if we ask some medical student to count the risk factors for heart disease, the psychosocial factor will not come into his mind because we always neglect the psychosocial factors, the behavioral factors or emotional factors of a human being, particularly that is the trend in India. So we must be very careful, and we now appreciate that psychosocial factors represent a huge risk for future coronary artery disease, topping or superseding many other conventional risk factors. Fourth in chart is abdominal obesity. Again, you see, we are not talking about body fat or BMI or body weight. We are talking about abdominal obesity, which is the villain of all kinds of body fat or all kinds of increased body weight. And that is contributing 20% of attributable risk in the population. Much down the list comes the blood pressure or hypertension, which is accounting for around 18%. Then the diet habit, vegetable and fruit intake if you do not take, around 13%. Exercise, if you do not partake exercise, around 12%. Diabetes, which is much down the list, is around 10% contribution to the attributable risk. And alcohol intake is around 6.7%. So if you count them and by regression analysis, you will see 90.4% of population attributable risk can be easily controlled if we take care of our lipid, our smoking, our mental health, our body proportion, our blood pressure, our food, exercise, diabetes control, and alcohol intake. Now, if we take one factor at a time, I'll be brief in just delineating what is happening. So ApoB by ApoA1 simply means LDL by HDL ratio. And if we see in the Interheart study that I just mentioned, that ApoB-APO1 ratio graded relation to heart attack risk, and there is no evidence of a lower threshold. So lower the ratio, the lower the risk. So LDL as low as possible, HDL as high as possible. And it starts even from 1, and if you extend the curve, you will get the benefit. So our aim is to reduce the LDL as low as possible and increase the HDL as much as possible. If you are genetically born like that, you are blessed. But if you are not like that, you have to recourse to exercise, to diet, and if necessary, the appropriate medicines. If we see in India, the raised LDL cholesterol, that is low density lipoprotein cholesterol, in observed up to 2/3 of coronary disease patient, and only 1/3 of patient can achieve the target we have set for a normal LDL or a good LDL. Raised LDL above 70 milligram observed in up to 70% of coronary disease patient in India, which came from Clarify registry. In DICES-2 study, only 1/3 of Asian coronary disease patient achieved the LDL target with the current therapy. And to complicate the matter, the threshold for normalcy is also decreasing with different recommendations coming from all over the world in every year. And nowadays, in very high-risk patient, the LDL threshold, safe threshold, is at most 55%, 55 milligram, and no longer it is 70 milligram. And by some recommendation from India, it is as low as 30 milligram. And if we see that lower LDL cholesterol is associated with increased risk reduction. So it is not a theoretical concept that if you reduce the LDL cholesterol, your risk will be reduced. It has actually been proved by genetic studies, by pharmacological lowering. And if you see, so many studies have conclusively proved that if you reduce the LDL cholesterol, your chance of cardiovascular risk represented by heart attack, angina, TIA, stroke, peripheral vascular disease, all will be reduced. And if you see what is the LDL level achieved, the lower the risk. I am not talking without evidence. If you see on the left panel, the TNT trial showed below 64 LDL is still better than 70, 80, or 90. If we see the Jupiter trial, we'll see that below 50 cholesterol, LDL cholesterol is better than above 50 LDL cholesterol. This is actually the foundation for the new recommendation. If we see the Prove-It trial, again we will see even below 40 is better than 40 to 60, which is better than 60 to 80, which is of course better than 80 to 100. So there is enough proof. And if you remember, these are not new trials. These have happened at least 10 years ago. And there is incremental benefit with LDL reduction more aggressively proved in over last few years, when you can see that even below 20 LDL cholesterol has got further incremental risk reduction by another 24% when it is above 20 to 50 milligram of cholesterol. So there is enough evidence that the lower the better. And there is now also enough evidence that the lower is safe. Very recent publication shows that very low cholesterol does not increase dementia, does not increase suicide rate, does not increase hemorrhagic stroke. But definitely there is increase of a little bit of diabetic prevalence and maybe some cataract. The ApoB by ApoA1. Now, ApoA1 is represented by HDL cholesterol. And low HDL cholesterol is a strong independent predictor of coronary heart disease, particularly below 40. Below 40 is definitely bad. Maybe in the females, you can go 2 milligram higher. But the problem with HDL cholesterol is that, number one, we do not have very effective pharmacotherapy to increase the HDL cholesterol. So we have to depend on physical activity to reduce the central obesity, and some diet like, say, fatty fat, marine fish, maybe some nuts, etc., can increase HDL cholesterol, because all the HDL cholesterol increasing trials have failed to prove the benefit. And also there is some evidence that very high HDL cholesterol may not give the protection. So 50 to 70 is the ideal range of HDL cholesterol to attain. Our second population attributable risk factor was smoking. And if you see low levels of smoking, the lower the level, the lower the heart attack rate. So if you have never smoked, compared to if you smoke, say, 20 cigarettes a day, then your heart attack chance is more than 5 times more. And this is reversible. This is very heartwarming information that if you stop smoking, even after prolonged use, decades of use, you can still get the benefit. How do you get the benefit? Within a few minutes of your last cigarette, your blood pressure settles down, your pulse rate settles down, and body temperature settles down. So as quickly as that, after the last fag you smoked, your pulse, pressure, and temperature get better. Within 8 hours, your carbon monoxide level in the blood starts declining and oxygen starts increasing. Within 24 hours, your heart attack risk starts decreasing. Can you believe it? If you stop smoking for a day only, your heart attack risk starts diminishing. Within 2 days, you will get back your smell and taste, and you will never know that you had a poor taste and smell. You will only know when you stop smoking and get the real thing. Within 2 weeks, your lung gets clear, your cough and congestion clear, you feel more energetic. Within a year, your heart disease risk decreases by 50%. And within a decade, risk of dying prematurely will be as much as a person who has never smoked. So within 10 years, you have totally come out of whatever problem you created in your body by smoking for, say, 50 years. And what are we doing to reduce the tobacco reduction in India? We have given warning to the tobacco products, banning tobacco in public place, in school, in offices. There is enough media publicity. If you go to watch a movie, you will see nowadays how aggressively the propagation is going on, which is actually very good. Extra levy on the tobacco product, but we are still short of banning tobacco in at least one state. Alcohol is banned, in 2 or 3 states, but tobacco is not banned in any state in India. That is a sorry state of affairs. So also there is help available to help you to get rid of the tobacco habit. There is, all adults should be assessed at every healthcare visit for tobacco use, and the status must be recorded as you record the pulse, pressure, and body temperature. So that should be a routine practice for all clinicians. To achieve tobacco abstinence, all adults who use tobacco should be firmly advised to quit, and a combination of behavioral intervention and pharmacotherapy are recommended as class 1A. In adults who use tobacco, tobacco abstinence is recommended to reduce the ASCVD risk. What is harm? That all adults and adolescents should avoid second-hand smoke exposure. So that is also very important. Even if you are a lifelong non-smoker, but your colleague in the office constantly smokes, or a person whose partner, whose consort husband or wife in the household is smoking constantly, he or she gets a equal harm of first-hand smoking. Third is the psychosocial factors. And as I have mentioned, psychosocial factors contribute to 32% of population attributable risk, but lo and behold, no recommendation in any guideline till only 1 or 2 years ago. Now we have realized it, we have taken measure. Now we are recommending yoga, pranayam, relaxation technique, outdoor games, particularly starting at the school level or at young adult level, but no age should be spared. Next come the obesity. And we have now known that overweight and obesity is being redefined from BMI to the abdominal weight to waist hip ratio to height waist ratio. So there are different ways to grasp the central obesity. In individuals who are overweight and obese, weight loss is recommended because that will reduce the AS, atherosclerotic cardiovascular incidence. Counseling and comprehensive lifestyle is very important, including diet and exercise. Calculating body mass index is still very easy and still the first line recommendation. It is reasonable to measure waist circumference, particularly in Indian subcontinent when our waist hip ratio is particularly bad. And if it is a very interesting study, so I included for you over here, that advertisement for sugary drink and mean body weight or the body mass index is actually related linearly. So in the countries or in the areas where there is a lot of sugary drinks are advertised like Coke, like Pepsi, like Sprite, in those areas, in those societies, in those communities, obesity risk is high. So it is to be taken cognizance of. Fifth point is blood pressure. And you see, high blood pressure is the commonest cause of death in the world. Not cardiovascular disease risk factor, but overall death is highest in high blood pressure people, which supersedes tobacco, cholesterol, malnutrition, unsafe sex, the unsafe bad diet, etc., etc. So high blood pressure is still the commonest cause of death in the world. And it has been shown, if you see on the top left corner, 20% of Indian school children suffer from hypertension. This study was actually so important that it was published in Times of India on 31st January 2019. Anita Saxena et al., they have proved this fact, and it created a lot of ripple in India. And you see, they took 4 states: Manipur, Haryana, Gujarat, and Goa, and they checked a huge number of young boys and girls in the school, and they found 20% are hypertensive, which is so bad and so disturbing. We actually did a very mind-boggling session on this, and after this publication, and we found that in India, 130/80 should be the target blood pressure. Everybody should have a blood pressure below 130/80, whatever be the age, even at the age of 70 or 80. And it was presented by me at Epicon 2019. Some very key recommendation. You just see the gist that age of 18 years and above is an appropriate age to initiate screening for hypertension. So every person starting their adulthood should have their blood pressure checked. And that is cost effective. Even if you have to take 1.4 billion people to do it, please do it, because that is absolutely necessary and cost effective for the health of the nation. Next is diet. And again, we go back to Salim Yusuf, who has again produced a very fantastic trial called Pure Trial, which included on-target, transcend, inter-heart, and interstroke study with 218,000 people from 50 countries. It was presented in an European Congress 5 years ago. And that countries included India, Pakistan, and Bangladesh, from where almost 30,000 people were studied, apart from all other parts of the world. And what we found is very interesting, that on your right is the blue thing, which are good, and on your left are the bad things. So which are good? Fruit and vegetable are good. We know that. Nuts and legumes are good. We know that. What we do not know, that dairy is good. And if you see on your right, the dairy is a milk and cheese and butter. They have proved that these are good for your health. Red meat, even the red meat is not too bad if it is lean red meat. Fish is good. Carbohydrate is not good. Fat as such is not bad, but it depends on the type of fat, and protein is neutral. So if you see the risk of mortality and major cardiovascular disease, if you go by this blue line, then you have got a 25% reduction of death if you take the good diet. The conclusion was more or less was conforming, but certain things were new, like dairy and meat, which were recommended as good food rather than bad food. And salt also is very important. WHO, World Health Organization, has told that wherever you live in the world, your total salt intake in a day should be 5 grams. That means 1 teaspoonful of salt, including the cooking, including the salted food, including the extra salt you take with your meals. So that should be a limit. There is a little controversy depending on whether you are living in a tropical country or not, which is your lifestyle, etc. But more or less it is 5 grams is the target. Next is the exercise, and it has been shown that physical activity on mortality has conclusively been proved in 130,000 people, again in the PURE study, and they showed that higher recreational and non-recreational physical activity was associated with a lower risk of mortality and cardiovascular event. So even a gardening, cycling, swimming, these are recreational activities. Tennis, badminton, table tennis. You don't have to jog, you don't have to go to gym. So even recreational physical activity is very good to prevent cardiovascular death. But at the same time, they have also shown that overexertion, overexercise may not be that good and may be detrimental, which you sometimes see that people just doing treadmill in the office and dying suddenly. So we have to assess how much your body can take, whether you are ready for exercise. And before ending, the diabetes, of course, if there is diabetes, you lose straight 6 years of your life. And if you have got a diabetes with a heart disease, you lose 12 years of your life. So diabetes must be checked and controlled. So here you see only diabetes or stroke or heart attack can increase the death rate by 2 times. If any 2 of these combine, then it is 4 times. And if all the 3 are present, then the 7 times higher chance of death than there is no risk factor. And there is enough guideline from all across the world how to control your diabetes. My last supposition is alcohol, and alcohol attributable death as a percentage of total death. It was an old study, but it showed that India is not too high. Around 2 to 5% of total death in India is due to alcohol, whereas certain European countries and South America, it is quite high, around 5 to 10%. And it has been shown again that Salim Yusuf trial that never drinker is good, current drinker is very, very bad. So you take less drink, but there was some controversy. Some people suddenly said a few years ago that moderate drinking may reduce heart disease risk, and everybody cheered and jeered. But we in India have proved that in Indian men, there is no protective effect of any amount of alcohol. So 1 or 2 drink is not good for Indian men. It may be good for Caucasians, but for Indian subcontinent, our liver, our system do not take alcohol very nicely. So just like smoking, alcohol should be abandoned as well. So before ending, this is my own thought process, which may help you, that why don't you do a weekly planner? What I suggest, that think, learn, and discuss about 1 risk factor every day of the week. Say Monday, you choose smoking. You talk about smoking. You search Google in smoking. You do group discussion about smoking. You stop smoking. On Tuesday, you check your blood pressure. You talk about blood pressure. You spread the news about blood pressure with your colleagues, with your children, with your parents. On Wednesday, you pick up for blood cholesterol. Again, you observe the diet. You check the Google, what is the latest recommendation. On Thursday, you think about sugar, what should be the diet, whether you are diabetic, whether you should check your blood sugar. Friday, you think about diet. You take fish, you take vegetable, you take legumes, you take dairy, and try to avoid the fatty meal, the carbohydrate meal, the fried meal. Saturday is the exercise day. Do some exercise which you like. You go to play tennis or table tennis or swimming or jogging, cycling. Sunday is relaxation, and relaxation means active relaxation, psychosocial relaxation, when you get rid of the stress and strain you have accumulated over the last week. So yoga, pranayam, and active relaxation for your Sunday. And I hope with that, you can enjoy a happy and healthy long life. Thank you.
Thank you, sir, for such wonderful presentation. We have few questions from our audience if you like to take that up.
Yes, please.
Thank you, sir. So the first question from our audience is, can you put some light on the increased cardiovascular risk in the boys born with hypopadias?
With
Hypopadias.
Can you spell it? Hypophosphadias.
Yes, sir.
Well, I am not very sure. Hypophosphadias in young boys, of course, that can cause atherosclerosis, but I am not very aware of the treatment or how to diagnose hypophosphadias, you said, no? Yeah, that is one of the risk factors, but I am not very sure. I'm sorry. You can check with Google.
Okay, sir. Now, sir, the next question is, how effective are electronic cigarettes for reducing respiratory and cardiovascular risk in smokers?
Now, it came with a lot of hope and hypes, but with gradually it has been shown that they are not at all effective. And if you see that in majority of places, they are banned equal, with equal footing as the normal tobacco use. And I have seen many patients, they're not getting good benefit out of it. Nicorette patch, the nicotine patches may be helpful. That is rather more recommended by international bodies, but electronic cigarette is never recommended by any international body. Nicorette patch is there, psychosocial counseling is there. We rather say that, the habit occurs in two ways. One is the blood nicotine level, and the second is your mouth addiction. That is something is sticking to the mouth or the lips. So there you can have some fake sticks like some lollipops or some kind of mixture, some kind of clove oil, etc., which can give the free feeling in the mouth that there is something there. And the blood nicotine level of nicotine can be countered by nicotine patch. But again, it takes about 7 days to 14 days to get rid of this habit if you are really determined. But electronic cigarette is not helpful actually.
Thank you, sir. So the next question from our audience is, what is your recommendation for the use of non-steroidal anti-inflammatory drugs and cardiovascular disease risk?
Non-inflammatory anti-inflammatory drugs, no? Non-steroidal. What do you mean? Non-steroidal anti-inflammatory drugs?
Yes, sir. Yes, sir. That one.
Yeah. There was a great much debate whether inflammation causes plaque rupture and can prevent a cardiovascular event. There is now evidence with use of colchicine. Colchicine, the Lodoco trial has been published, and they have proved that colchicine, which acts just purely by anti-inflammatory pathway, can reduce significantly the cardiovascular events. But that is not the usual colchicine we take for gout. There's a different preparation with a small dose, with a different packaging. It is being promoted in the Western world, not easily available in India as well. But yes, there is a good case for anti-inflammatory therapy, and not only colchicine, newer medicines are coming, including monoclonal antibodies, which can tackle the in ongoing inflammation. That's why in chronic inflammatory processes like rheumatoid arthritis, like SLE, like psoriasis, there is a higher incidence of coronary artery or atherosclerotic disease, and they have been already identified as risk enhancers. If you see the Q risk score, you will see the rheumatoid arthritis, SLE are already there. So these are also very important. So if the person has got a chronic inflammatory condition, that has to be tackled very properly, which includes inflammatory bowel disease, which includes all kinds of arthritis and connective tissue diseases. But also, even without those, colchicine has been proved its worth to prevent heart attack.
Thank you, sir. The last question from our audience is, can we apply cardiovascular protection with sodium glucose co-transporter 2 inhibitors in type 2 diabetes to all the diabetic patients?
Yes, of course. It is now almost class 1A recommendation that SGLT2 inhibitor, particularly empagliflozin and dapagliflozin, are absolutely good. Very significantly, they reduced the atherosclerotic cardiovascular disease, the heart failure incidence, as well as the renal deterioration. So any people who at the baseline has got, in a diabetic person, say, he has got any atherosclerotic risk factor, high risk category, or heart failure or CKD, he should have SGLT2 inhibitor. Secondly, any heart failure patient, whether it is reduced ejection fraction or normal ejection fraction or preserved ejection fraction, they should all have SGLT2 inhibitor, irrespective of their diabetic status, irrespective of their renal status. Similarly, all renal patient, diabetic or non-diabetic, heart failure or non-heart failure, should have SGLT2 inhibitor to prevent further deterioration of the renal disease. So SGLT2 inhibitor has got a very wide indication now in all cardiorenal, atherosclerotic, and heart failure diseases, irrespective of diabetes. So yes, it is a highly recommended drug in such setup to, as you said, to prevent heart attack or not. That includes the high risk patient. It is very clearly shown that in high risk patient, if you give SGLT2 inhibitor, you prevent a fast heart failure or prevent a fast heart attack or prevent deterioration of kidney. So you can say it is a preventive medicine as well.
Thank you so much, sir, for answering all the questions from our audience. So before concluding today's session, any last concluding remarks from you, sir?
My concluding remark will be, we should know our figures. Figures doesn't mean the vital statistics, or vital statistics does not mean what we conventionally mean. Vital statistics means your blood pressure figure, your blood cholesterol figure, your blood sugar figure, your BMI or abdominal girth figure. So if we take care of these figures and figure of the number of cigarettes you take a day, it should be 0 figure. So if we take care of our figures, we will live happily with a good figure. So that is my last message to you.
Thank you, sir. Thank you for joining us today. With your permission, I would like to conclude today's session.